Good evening, ladies and gentlemen. Welcome to the 10th episode of the KSOS Online Journal Club. I'm Dr. Smita Narayanan, and I'm the editor of the Kerala Journal of Ophthalmology, and I'm also a professor at the Regional Institute of Ophthalmology, Trivandrum. With me today are Dr. Anisha Teresa Agustin, Assistant Professor at the Amala Institute of Medical Sciences, Thrissur, Dr. Shweta, who is a consultant at the Jyotis Eye Care at Kannur, Dr. Satyan, who is the director of Satyan Eye Care Hospital at Coimbatore, and Dr. George Puthuran, who is the head of Department of Glaucoma Services at Aravind Eye Care System Services, Madurai. Now, today, the article for discussion is the primary tube versus trab study, the 3-year outcomes. This article by Dr. Stephen Geddy et al. Was published by the American Academy of Ophthalmology in March 2019. Basically, reading a published article in a journal is an art. The KSOS Journal Club has endeavored to train the readers by highlighting the salient features of the articles, the more important articles. And we usually do it by a 3-step process. First is to summarize the article, and then second is to provide a critical appraisal of the article, and then finally we give a discussion. So today, we begin this journal club with Dr. Anisha presenting the summary of this article and also of relevant similar articles. Dr. Anisha.
Hello.
Yes.
Am I audible?
Yes, Anisha, you are audible.
Okay. Good evening, everybody. And first of all, thank you to KSOS and to Smita Madam for giving me a chance to present this journal. So today I'll be presenting the treatment outcomes in the primary tube versus trabeculectomy study after 3 years of follow-up. This was published in March 2019. It was done by Dr. Stephen Geddy and team in the American Academy of Ophthalmology. So what was the aim of this study? It was to report the 3-year results of the primary tube versus trabeculectomy study. That is to compare the safety and efficacy of the Behrwell implant versus trabeculectomy with mitomycin C. So the question was, do you want to put a tube or cut the trab? Before we go into the article proper, a few related studies. The first is the TVT study that was published in 2005. They said that the rate of surgical success with survival analysis was higher with the tube shunt compared to the trab at 5 years. Now, our study, that is the PTVT study, their 1-year result that was published in 2018 said that trab with MMC had higher surgical success rate than the tube shunt. Lower IOP was achieved with the use of fewer glaucoma drugs in the trabeculectomy group, but the post-operative complications and serious complications were more in the trabeculectomy group. Just an introduction. So the glaucoma implants, we have valvular and non-valvular. So Behrwell is the non-valvular type of implant. This is a picture of the Behrwell glaucoma implant. Now in this study, we're going on to the methods. So an unmasked randomized controlled trial was done from 16 centers. And their sample size was 242 patients. Only one eye of each patient was included into the study. It was conducted from May 2008 to March 2015. The inclusion criteria were patients were from the age group 18 to 85 years, those who have not undergone any previous incisional ocular surgeries, and inadequately controlled IOP. This is more than 80 and less than 40 millimeters on tolerated medical therapy. What were their exclusion criteria? No PL vision, pregnant or nursing mothers, narrow anterior chamber, neovascularization of the iris, or any proliferative retinopathy, iridocorneal endothelial syndrome, epithelial or fibrous downgrowth, chronic or recurrent uveitis, steroid-induced glaucoma. Severe posterior blepharitis, unwilling to discontinue contact lens after surgery, previous history of cyclodestructive surgery, conjunctival scarring, significant cataract, need for glaucoma surgery along with other ocular procedures, and patients who are unwilling to give consent, unwilling for randomization, and unwilling for regular follow-up. So as I previously mentioned, 242 patients were chosen for the study. And after randomization, they were put into two groups. One group received the Barewell glaucoma implant, and the other group received trabeculectomy with mitomycin C in the concentration 0.4 mg per ml for 2 minutes. 125 patients were in the implant group, and 117 patients were in the trab group. Now, patient visits were scheduled as follows. Initially, their baseline parameters were recorded before treatment, and follow-up after treatment was as follows: 1 day, 1 week, 1 month, 3 months, 6 months, 1 year, 18 months, 2 years, 3 years, 4 years, and 5 years. Now, what were the definition of their outcomes? So the primary outcome was the cumulative rate of surgical failure at 1 year. Additional reports were published at 3 years and 5 years. Secondary outcome measures were intraocular pressure, use of glaucoma medical therapy, visual acuity, and surgical complications. Failure was defined as intraocular pressure more than 21 millimeters of mercury, less than 20% drop in IOP from baseline on 2 consecutive follow-up, even after 3 months. IOP of 5 mm or less on 2 consecutive follow-up after 3 months, reoperation for glaucoma, and loss of PL vision. Success was divided into two. One was complete success and the other was qualified success. So under complete success, there's no failure or no supplemental medical therapy. Whereas for qualified success, there is no failure but patient required supplemental medical therapy. Post-op complications were divided into early and late. Early were less than 1 month duration, and late, which developed after 1 month duration. Serious complications were loss of more than 2 lines of Snellen's visual acuity, and those who needed reoperation. Statistical analysis was done using the two-sided student t-test, chi-square test, and the Kaplan-Meier. I think that will be discussed later. So what were their results? So these were the baseline characteristics, some of the baseline characteristics. It was a very long table. That's why I included just the salient features. So age of the patient, in the tube group, the mean age was 62, and in the trab group, it was 60.8. Most of the patients were males. Intraocular pressure, in the tube group, the mean intraocular pressure was 23.3 plus or minus 4.9. And in the trab group, it was 23.9 plus or minus 5.7. The number of glaucoma medications in the tube group was 3.1 plus or minus 1.1. And in the trab group, it was 3.2 plus or minus 1.1. Majority of the patients had diagnosis of primary open-angle glaucoma. Now the treatment outcomes. So the treatment failure in the tube group, 41 patients had, which came up to 39%. And in the trab group, it was 30 patients, that is about 30%. The p-value here is 0.17, which says that it was insignificant. Now, complete success, there were 14 patients in the tube group, that is 13%. And in the trab group, it was 44, that is about 44%, p-value less than 0.001, which is a significant difference. And qualified success was 51 patients in the tube group and 27 patients in the trab group. The cumulative probability of failure was 33% in the tube group and 28% in the trab group. P-value 0.17, so there was no significant difference. So these were the causes for failure, inadequate IOP reduction. In the tube group, it was 26, and in the trap group, it was 18. Reoperation for glaucoma, persistent hypotony, and loss of PL vision. Now, the intraocular pressure, the mean intraocular pressure reduction from the baseline was 39% in the tube group and 46% in the trap group, p-value 0.08. And the number of glaucoma medications decreased from the baseline. That is, lower IOP was achieved with fewer medications in the trap group compared to the tube group. The p-value was less than 0.001, which is significant. Now, vision. Reduction in visual acuity occurred in both groups in the first 3 years, but there was no significant difference in the rate of vision loss between the treatment groups. Now, progression of cataract. The 3-year cumulative rate of cataract extraction was 32% in the tube group and 33% in the trap group. It occurred in 51 patients in the tube group and 42 patients in the trap group. So this is the table showing the visual acuity in the tube group and the trap group. We can see that the baseline visual acuity by ETDRS was 73 plus or minus 20. In the trap group also it was 73 plus or minus 20 at 3 years. It is 73 plus or minus 21 in the tube group and 71 plus or minus 23 in the trap group. The Snellen's visual acuity at 3 years, at the baseline, it was 0.20 plus or minus 0.42 in the tube group and 0.25 plus or minus 0.51 in the trap group. At 3 years, in the tube group, it is 0.30, and in the trap group, again, it is 0.33. Okay. Now, the rates for reoperation for glaucoma in the tube group, 18 patients required reoperation for glaucoma, which is about 16%. And in the trap group, 10 patients required reoperation for glaucoma, that is 9%. Post-operative interventions, 108 patients required post-operative interventions in the tube group, that is 62%. And in the trap group, 126 patients required post-operative interventions, that is about 66%. Now, coming on to the post-operative complications, the early complications, you can see that it is more in the trap group. That is, only 25 patients had early complications in the tube group, whereas 39 patients or 33% had early complications in the trap group with a p-value of 0.028, which is significant. The late complications, 27 patients, that is 22% in the tube group, and 29 patients or 25% in the trap group. So the reoperation rate for serious complications were no PL vision, were 3% in the tube group and 8% in the trap group, that is 0.059 with a log rank test. And 3 patients, which is 2% in the tube group and 9 patients in the trap group required additional surgery to manage complications. Now, the limitations of the study were that the study was performed on patients who met specific criteria. Hence, it cannot be generalized to the different patient groups, and no standardized definitions of quantification of surgical complications were used. There was variation in surgical technique among the surgeons according to their comfort levels. Small patient subgroups and hence low incidence of certain complications limit the power of the study to detect significant differences. And patients and investigators were not masked. So that was a potential source of bias. And there were multiple test artifacts. So to conclude, there was no significant difference in the rate of surgical failure between the two procedures at 3 years. Both were effective in lowering IOP. However, there was greater IOP reduction with the use of fewer medications in the trap group. And serious complications occurred with similar frequency in both the groups. Now, just the latest update, the PTVT has published its study at 5 years also in 2020. So, trabeculectomy with mitomycin C and tube shunt surgery produced similar intraocular pressures after 5 years. Again, fewer glaucoma medications only were required after trabeculectomy. There was no significant difference in the rate of surgical failure observed between the two surgical procedures at 5 years also. Thank you. Over to you, madam.
Yeah. Thank you, Anisha. That was a succinct summary of the primary tube versus trap surgery. And now I request Shweta, Dr. Shweta, to give us the critical appraisal of this study. Dr. Shweta.
I think the doctor has to exit from the presentation so that other person can do the presentation.
Anisha?
Yes, madam.
Have you? Yeah, you have exited. Okay. You remove your presentation. You're sharing your presentation. Remove it, please. Yeah. Still sharing. Yeah. Now it's okay. Dr. Shweta? Dr. Shweta, can you join us?
She has to unmute herself.
Dr. Shweta, please unmute. Yeah. Can you share the screen? Hello, Shweta. Unfortunately, Dr. Shweta is finding it difficult to share the screen. So why not have a discussion first, and then like she can present a critical appraisal after the discussion. What do you say, Dr. George?
Sure.
What do you say, Satyan sir?
Yes, please. Yes.
Okay. Let us have a discussion on this topic of primary tube versus trap. So I am inviting Dr. Satyan sir and Dr. George Puthuran for this discussion. They are two eminent glaucoma surgeons from Tamil Nadu. So Satyan sir, the first question is directed towards you. What is meant by medically uncontrolled glaucoma? How do you define it?
Okay. Just looking at that now, the entire thing is different because each individual, the maximum medical therapy is different. In the sense, somebody may accept only one medication, the remaining may not be possible for us to give them, or the control is not there. You can look at it in many different ways. There is no standard thing for the maximum medical therapy. Now we call it as a maximum tolerated medical therapy rather than saying it as a maximum medical therapy. Yeah.
So, so you mean to say you individualize it according to each patient?
Absolutely, yes.
Okay, sir. So supposing
that's why the terminology is called as a maximum tolerated medical therapy rather than saying that as a maximum medical therapy, which used to be there in our own times. We used to give, say, whether the patient is tolerating or not. We just give all the medications to see whether the IOP is under control, like you, including Diamox or IV mannitol, everything you give. And then see, that is called as a maximum medical therapy. But nowadays that is not existing anymore, I feel at least. Now it is maximum tolerated medical therapy is a better terminology to use, and also it makes more sense to use.
What is your opinion, Dr. George?
I agree with what Dr. Satyan said about maximum medical therapy. It's to maximize the therapeutic effects, minimize the ocular adverse events, and also to make it a more comfortable regime for the patient. And with the advent of many FDCs now, you are able to combine so many classes of medicines, and it becomes much more easier. The installation regime becomes much more easier for the patient. In fact, actually, the initial definition was for maximal medical therapy, as what Satyan said about maximum tolerated medical therapy. It was use of 3 or more different class of glaucoma medications. Now, if you can have a prostaglandin and a beta blocker FTC used once at night or once in the morning, plus alpha agonist and a topical carbonic anhydrase twice or thrice. So the number of drops that going into the for the patient is much less compared to earlier times.
Yes, sir. So this whole concept of maximal tolerated or maximal medical therapy has gone a sea change with the different kinds of drugs, and also dependent upon the individual who is going to take the drugs. So the second question is directed to you, Dr. George. What are the common indications for implanting a glaucoma drainage device in your practice?
So the most common indication is medically uncontrolled failed trabeculectomy. So you have a failed trabeculectomy and you give anti-glaucoma medications, still the pressures are high, there is progression of glaucomatous. So a failed trabeculectomy, which is medically uncontrolled, or in certain situations where a trabeculectomy has a high chances of failure. Especially in our practice, there are 2 areas here. One is glaucoma in aphakia. It can be glaucoma in congenital glaucoma following congenital cataract surgery, or any aphakic patient uncontrolled on maximum medicines, and also a group ocular phacomatoses, especially the Sturge-Weber. So these are 2 groups where trabeculectomy, glaucoma surgeons often feel that trabeculectomy is highly unlikely to succeed because of high risk of intra and post-op choroidal effusions and suprachoroidal hemorrhage. Then there are a whole lot of secondary glaucomas which do extremely well to a primary tube, like a neovascular glaucoma, a uveitic glaucoma, an epithelial or fibrous ingrowth. Many eyes which have already undergone previous ocular surgeries, like post-vitreoretinal surgery, post-silicone oil removal, patients with encircling bands, a post-PKP. So any patient who has had a previous intraocular surgery is a good candidate for a tube implantation. Several secondary childhood glaucomas like aniridia or Axenfeld-Rieger syndrome, in our hands, tubes seems to work better than a trabeculectomy with microscope. Also in primary congenital glaucoma, where your angle surgery has failed, or a failed trabeculectomy, is an indication for a tube implant. So these are some of the indications in our hands.
Satyan sir, would you like to add to what Dr. George has told just now?
I think George just mentioned most of it. Only thing is to be more like a theoretical. I would say like where do you really do the primary tubes, and when will you do as a secondary procedure? That's only a modification. I can just do that. And also probably when we go a little deeper, where will you do the valved devices versus the non-valve devices? That will be probably a few additional points we can add. Like what George was mentioning, when we are looking at the NVG or like other secondary glaucomas in the childhood glaucomas, or sometimes, let's say, for example, glaucoma in aphakia, we don't say anymore aphakic glaucoma. Aphakic glaucoma is a misnomer. We have to say it's a glaucoma in aphakia because we don't know the cause. It is again a multifactorial. So where we go for only a valve devices. We don't go for a non-valve device in a glaucoma in aphakia. Also in uveitic patients or in, like a glaucoma in post-RD surgeries. So some of these cases, we go for a valve devices than going in for a non-valve devices. But the primary indication, at least in our patients, is going to be mostly the NVG patients or these childhood glaucoma sometimes, the secondary childhood glaucomas. I'm just broadly saying, but we can always go for a little deeper discussions.
Dr. George, do you have any different indications for the valve and the non-valve devices from what Dr. Satyan mentioned?
I may be a little biased, but still, the absolute indication for a valve, that is an Ahmed glaucoma valve in our practice now, our absolute indications are neovascular glaucoma and uveitic glaucoma. Because in neovascular glaucoma, the pressures are so high, and every 2-3 days, you can see the vision dropping. You need immediate IOP control. It's an absolute indication in our hands as of now for a Ahmed glaucoma valve. And in uveitic glaucoma, the incidence of hypotony following tube implants, or for that matter, any glaucoma surgery, the incidence of hypotony seems to be a little higher, and we prefer to put in the Ahmed glaucoma valve rather than the non-valve device. But then the others are the other indication, relative indication for an Ahmed glaucoma valve is where you don't want to risk hypotony, and that is you have a patient, a monocular patient with a very advanced glaucomatous optic nerve head, a highly compromised visual field. That is an indication where probably we would go in for a valve device than a non-valve device. Glaucoma in aphakia patients, if the optic nerve head is reasonably good, optic nerve head is not highly compromised, I would still risk a non-valve device. And if it is highly compromised optic nerve head in a glaucoma and aphakia, again going for valve device.
That was a very good summary of valve and non-valve device, because most of our audience are mostly postgraduate students also. So they will also get a fair idea of where preference is given for the valve and the non-valve device. Now coming back to our study, the PTVT study, the primary tube versus trap study, is about mainly about primary open angle glaucoma and its allied forms like pigmentary glaucoma and pseudoexfoliation. Rather than about those secondary glaucomas that both of you have mentioned. So has the PTVT study affected your practice or your surgical decision making? If so, how has it done so? Dr. George first.
Before I forget, I would like to congratulate Dr. Anisha for that wonderful presentation. Actually, most of the journal clubs, we see people just taking and pasting from the article, but the salient features were very well covered in this presentation. I forgot to say that in between. Coming back to your question, Dr. Smita, I don't think PTVT has in any way changed our practice, because as Dr. Anisha had said, there is no indication for a primary tube in an eye which has not undergone prior incisional surgery. So there is no advantage of risking a tube ahead of a trabeculectomy in a patient with no prior intraocular surgery. And everything more points more towards trabeculectomy having a better success rate, a lower IOP with fewer medications. I think the only thing the authors want to highlight here is that early post-operative complications following trabeculectomy, early serious post-operative complications are more in the trabeculectomy group compared to the tube group. And I feel the authors want to highlight the fact that any increased efficacy has to be balanced with the adverse events of the surgical procedure. I don't think this is affected our practice in any way. We continue to do trabeculectomy with with antimetabolites as our primary surgical option for glaucoma.
Satyan sir, would you like to add something to Dr. George, or how has the PTVT affected your practice?
First of all, again, like what George was mentioning, I just really wanted to congratulate Dr. Anisha for her wonderful presentation. It's a nice way to do the presentation, Doctor. Like what George was mentioning, salient points, it's short and sweet. Good. Keep it up. So coming back to the journal as such, looking at my practice, I'm really thankful to the presenters, the published authors, because we are strong now and say, okay, we have been doing a good job all these years without moving into doing the, tubes as a primary in POAG. Our routine teaching is always do the trap first and then SOS tube later. So the typical way what we do is, once you see that the trap is not working within the first 2 years, that is the time where you may think of going in for a tube. The trap is going in for a failure. Say, for example, only after 2 years of your procedure, then again a repeat trap is always a better choice. At least that's what we have been doing all these years. Just looking at this article, it is really useful in one way, that a lot of us do have a confusion saying that whether the tubes are going to be probably a better choice when you're looking at the glaucoma practice. But this has really helped, this article has really helped. But when we have the discussion, we'll be able to understand better, because that traps has shown a better results, though we have seen that the complication seems to be slightly on the higher side with the trap. But when you are looking at the critical points in this, is they have used 0.4 milligram per deciliter as the concentration, which we don't use it. Because I have seen the eyes when I was in US, both the centers, Boston Palmer and also in the Wilmer, they used to have a huge blips because of the 0.4. The amount of inflammation what the Indians or the Africans have and the scar tissue formation, if we use 0.4, or even in the African eyes when we use 0.4, we may not have that kind of a blips. But I've done both the British and also the white population. But then they have a huge blips when you use even a 0.2. So 0.4, I feel, is a bit on the higher side, the concentration. That might have helped them to achieve a better IOP control in one way. The other way, probably they would have had a more lowering of IOP, like 5 or lesser, where they would put it as a complication also. So it works in either way. Both they will have more complications, and also they will have a better IOP control. So that's what I have looked at in this particular article. But the one thing which we can understand is there is no point we going in for a tube as a primary procedure according to this article, and also all our Indian experience. But I'm not really sure about the African eyes or in the the Gulf countries. I feel it may be completely different scenarios, because I've done surgeries in African eyes and also in the Gulf countries I'm doing currently also. But these eyes are completely different. So saying that this will hold good for every population may not be the ideal way to look at it. So that has to be a really critical analysis has to be done in every country, every population, to get the best of it. Because within 3 months' time, both the African eyes and the Gulf countries, the surgical results are so poor in trap, because I've been doing there, but the results are extremely poor. And I'm sure 100% of the time, I'm sure that these eyes will go for a failure. So I'm not sure whether we can really just follow the same ditto of what has been presented in this article to other population also. That's what my take-home message is. Okay, there's a presentation, published article is there. good to see that the trab is probably a better option in those patients. Yeah,
So they
probably we'll have
actually,
more discussion when it comes. Yeah.
yeah, they had actually stratified based on the age and the race and the failure of trab in the other eye. That
Yeah,
is how.
but then when you look at the race, the African American, the population in that study is quite less. It's mostly the white population. The numbers are pretty less to come to some conclusion in that. And also, when you look at the African American population, a little bit of a controversy whether the husband and wife both are African, or one is an African, other is a non-African. We don't know. So the things can be completely different also.
So, but if one eye has a failed trab, would you prefer to do a trab again in that eye, or would you prefer to do a tube in that eye?
That's exactly I was mentioning earlier. If the failure is happening within the first 2 years,
Yes.
then definitely a trab is not a good option to go for. You can go for a tubes. Also, when you have these eyes, say for example, you have put on multiple medications and this eye looks so bad, definitely that going in for a trab is not a good option. And also you have to look at the conjunctival mobility. How large is the first trab, the area they have taken? If it is like, the complete superior area they have done and so much of a scar tissue, there is no point in we going in for a repeat trab in that area. Even if you do the temporal trab, the chances of failure is much higher. So it is the location, the amount of scar tissue formation, associated ocular surface changes because of the medications usage and other issues, or the inflammatory response what the patient has, say for example, other causes of intraocular inflammation. There are so many things which we need to consider before we go for either a repeat trab or a tube. It is not just one thing which you can just look at and blindly go for a trab or tube. It's not a good idea.
I was actually thinking about that inflammatory response of the trab. A failed trab would mean that there would be a lot of inflammatory material or cytokine circulating, which could lead to the failure of a subsequent trab. So wouldn't rather a tube be a better, as you have pointed out, the tube should be the logical better option in a failed trab in the same eye?
It's very difficult, Dr. Smita, because the surgeon who has done the first time surgery would know exactly what the problem went. Whether he has put a tight sutures, whether he had a bleeding, whether he has touched the perforators where they had a lot of bleeding, and also how big the ostium he had taken, and whether there was iris incarceration, how small the ostium was. There are so many contributing factors. And post-operatively, how the patient has applied the drops, how much of the inflammation was there, whether the patient had a shallow chambers. There are so many contributing factors for a failure of a trabeculectomy when you're doing. And surgeon will know exactly what he has done. He can always deny saying that I didn't have any complications. And he can say that, okay, I'm going to do a repeat trab or a tube. That's difficult. What I'm saying is we have to consider all these points before we come to a conclusion of whether you want to do a trab or tube. But of course, I told you other points as well earlier, the amount of scar tissue formation and other associated inflammatory response, medications, so on, so on. There are so many factors which we need to add. So doing a trabeculectomy, when I can do, you can do. It's not a big deal. But in a glaucoma surgery, the main thing is understanding about the conjunctiva, understanding about that eye, and logically thinking about all other associated factors to take a decision, and also managing post-operatively. That is what is more critical than the procedure as such. Once you do many numbers, then you will slowly start understanding when you want to do, when you don't want to do it. Basically, the glaucoma is a surgical disease. I've been saying this for so many years. In fact, the recent one of the lectures by Dr. Alan Robin, he was also mentioning that it is basically a surgical disease. But many of us are a little reluctant as there are many medications that come into the market. But for me, if we can do the trabeculectomy much earlier, the surgical success is always going to be much, much better. Whether you use a non-BKC medications or BKC medications, the conjunctival cytological changes with the multiple medications, and also the longer duration of medications is going to spoil the conjunctiva almost for sure. So I think I'm kind of a little deviating from the publication, but I thought it is important for the people to understand the logical thinking in glaucoma, whether it is a surgical management or it is a medical management, is going to be the most essential factor one has to understand.
I have another question to Dr. George. It is basically about the tube versus trap study, which was a predecessor of the PTVT study. Why are the results in the tube versus trap different from what is there in the PTVT study? What is it according to you?
Actually, I think there is a small 2-3 lines in the third last paragraph of this PTVT study explaining why the results of this PTVT study are a little different from the previous published literature on tube versus trap studies, especially the TVT study. They say that the study designs the severity of the disease in the patient population, the different surgical procedures, the length of the study. There are a lot of things they have mentioned. I was not able to find a reason for the difference, why the PTVT results were behaving little different from the TVT study. Probably the reason is the TVT study included patients with very low risk of filtration failure, actually, very low risk of trabeculectomy failure, which means you have positioned tubes much earlier in the glaucoma surgical armamentarium than which we usually position. Having said that, even in the PTVT, the majority of the patients are POAG. I don't think I have a clear answer for that. And just to add on to what Dr. Satyan was saying about doing a repeat trabeculectomy or a tube in a failed filter. So both the TVT and the PTVT says surgical experience and training in a particular procedure also is a major factor which has not been analyzed in either of these. So if a person is comfortable doing a trabeculectomy, 5 years the trap has worked as well. Both these studies equivocally says you can repeat a trabeculectomy. But in my practice, in our practice, our threshold for repeating trabeculectomy is quite low, actually. We go in for a tube once the trabeculectomy has failed. And once the trabeculectomy has failed. And there's another one important thing I wanted to point out was, there was this question on putting in a tube in a POAG patient with no prior intraocular surgeries. There is a recent pooled analysis which was published, TVT versus PTVT. And in that, they have said high intraocular pressures, patients presenting with very high intraocular pressures, even on maximal medical therapy, trabeculectomies tend to fail more than tubes. And probably in future, like these are patients who come with very rarely, but they once in a while they do present with pressures of 40, 50 on maximum medical therapy. And probably tubes are a little bit safer than a trabeculectomy in this. And probably in future, even a highly compromised optic nerve head may also become once somebody presents some data on that also may be an indication for doing a primary tube in POAG. Also the medications which Dr. Satyan said, I am sure that these medications are literally spoiling the conjunctiva. All these and the younger patients, I think we need to just give a little bit of timolol and do a trabeculectomy for this patient. Absolutely. And once you do the trabeculectomy, you can make out holding virgin conjunctiva is. And you know that the trabeculectomy is going to work, unlike in some of these eyes treated for long with prostaglandins, especially the bimetoprost and the travoprost. there is so much of deepening of the lid sulcus, absolutely no exposure, narrowing of palpebral aperture, loss of periorbital fat, and the worst is the severe conjunctival inflammation that we encounter in these patients. And trabeculectomies are prone to fail. I just have one.
Doesn't move.
Yeah. Just one question for Dr. Satyan. He was mentioning that this study doesn't say that trabeculectomy would do well in Black population. So would he be advocating primary tubes in POAG in Black population?
My simple answer is I really don't know. Because when I did I think I did 90 surgeries in 5 days in Nigeria, the trab alone. But then unfortunately, the failure rate is really, really so high that because the inflammatory response and the scar tissue formation, I won't say the inflammatory response, the scar tissue formation is really very high. And also, if you really look at the eyes at the UAE, where I operate, the eyes are completely different. It is not like our eyes. Because of the exposure to sun, I don't know, is it exposure to the dust? The scar tissue formation is so high. The moment you see that eye, you can be really sure that, okay, if I do the trap, it will go for failure 100% of the time. But then now we have the option of doing a cyclogy first when you have the higher IOP, reduce, and then you can go for either a trap or a tube or whatever the way you do it. But in these two populations, I really feel I don't know what to do. Whether you do the tubes as a primary procedure, but the patients in the Gulf countries, I really feel completely different. I'm not talking about the NRIs at the Gulf. They may have a different outcomes because they are Indians and other population also. But I'm talking about the pure Gulf people, because those eyes are completely different. It's difficult to explain, but the scar tissue and these conjunctivas are completely different from what we have. So that's why I'm saying the PTBT study, definitely it is good for their own population and their outcomes, because they've used 0.4 also. The response to 0.4, both for the European eyes and for the American eyes, are going to be much more severe. If you use 0.4 in the African eyes and in the Gulf countries, it may not be, it may be the just normal appearing conjunctiva. They may not have even a large blebs. So it's completely a different kind of a response you will get it. But when we use it in younger patients, 0.4, we really may not get much of a blebs, in the sense either in the congenital glaucomas or in the adult glaucomas, the younger ones who have a very thick tenons, they may not really show up much of a large blebs or the cystic blebs. But those with the thin conjunctivas will definitely is going to have more and more problems, even if you use 0.2 for 2 minutes. So 0.2 for 1 minute may be a better option in this size. So it's really, understanding of these eyes more than patients, understanding of that particular eye is going to be a more critical choice than just looking at overall things. Overall things will not suit for glaucoma. It has to be completely individualized. Welcome, Shweta, for this meeting. I'm not sure whether your slides are up or you have still difficulties.
No, sir, I think I'm back. Shall I share my screen?
Shweta,
Yes,
just a minute. I would have loved to hear from Dr. George about his journey with the RD, Oral Lab Aqueous Drainage Implant. And just after Dr. George finishes, you may share your screen. Okay?
Okay,
Shweta, I don't know whether we have sufficient time for Shweta to present that. Maybe she can present and then I can just summarize the 2-3.
Okay, because I think many of our participants would be wanting to hear from you about your journey. So I thought that would be pertinent. Sure. Okay, let's Shweta
we would like to hear, but let the birthday girl present her talk today and then we'll just listen.
That's news.
Thank you, sir.
Happy birthday, Shweta.
Thank you, ma'am.
Please present.
Unfortunately, I had some technical issues. Can you see my screen?
Yes, yes. Make it full screen.
Okay. Warm good evening to all. Thank you, KSOS and Dr. Smita ma'am, for giving me this opportunity. So my duty today is to do the critical appraisal of the journal. So what is a critical analysis? It is a process of systematically evaluating and assessing a research to determine its quality and validity. It's important when you see a journal, you have to analyze each journal that you read so that you can know whether to take the points, whatever they have told, whether we can trust those data or not. That is the importance of the critical analysis. So we know that our topic for today, the journal is the treatment outcome of the primary tube versus trabeculectomy study. And this was published in the American Academy of Ophthalmology, March 2020. And this is the title and the abstract. So from this, we know that it is a randomized control trial. So for a randomized control trial, we use the CONSORT 2010 checklist for checking the journal. So this is the CONSORT for the abstract checking. So first, let us see the title and the abstract. So title is a treatment outcome in primary tube versus trabeculectomy study after 3 years of follow-up. So here condition of interest is surgical management of glaucoma with tube surgery or trabeculectomy, and the variables are difference in the treatment outcome. Now time period is 3 years and they have given it as a follow-up study. So it is a prospective study. So the title conveys a core objective of the study, but title doesn't indicate randomization. Now then we look at the abstract. So what is the importance of having a well-structured abstract? So it helps the reader to know quickly understand whatever the researcher is trying to analyze. So it should be well structured. For that, we have some points. We have to see whether all these points are there in this abstract or not. First is a trial design. So here the trial design, they have given it as unmasked multi-center randomized control trial. And participants, they have shown how many participants are enrolled and how many are randomized in each group. And methods also, it shows that it has been done in 16 clinical centers. And the two groups, the Barwell implant and the trabeculectomy with mitomycin with the concentration is given in the abstract. And the purpose to report the 3-year results of the primary PTVT study and the main outcome measures. The main outcome measures, we have the primary outcome measure and the secondary outcome measure, which is also beautifully described in the abstract. I'm not going into detail of whatever is given here because it has already been mentioned by Anisha. I'm just trying to understand whether everything is mentioned in the abstract or not. So the results of the study given as cumulative probability of failure, the intraocular pressures, the glaucoma medications, and the reoperations, everything is given in the abstract as well as a conclusion. So the abstract of this particular study is a well-structured one. So coming to the research question, the research question is to compare the safety and efficacy of tube shunt surgery and trabeculectomy with mitomycin C in eyes with medically uncontrolled glaucoma without previous ocular surgery. So when we see it in the PICO format, the population is the patients with medically uncontrolled glaucoma without any previous intraocular surgery. The intervention is a surgical management in the form of trabeculectomy and the tube shunt procedure, and the outcome is the cumulative rate of failure. Now, introduction part, they have given a brief introduction of what they are going to study. Now, coming to the methods, we have to see the study design. So this is a prospective study. It is an interventional study, and it is multi-centered and randomized control trial. So we have to think of whether this study design is apt for this particular study or not. So it is an interventional study, so we definitely need a prospective study. If we take a retrospective study for the same, to compare the same trabeculectomy and tube, for example, all the complications that we are going to get, even the minor complications like blood leaks, those will be missed in these retrospective studies, because if the surgeon is considering them as a insignificant complication, they may not note it down. So always a prospective study is better for such a study. Now, also they have shown that it is a parallel assignment and an open label study. And this is taken place in a multi-center, that is 16 centers, and there will be a multiple surgeons who are operating. So we have to think of how confident each surgeon are in each surgery. We know that some of the surgeons will be better in trabeculectomy, some will be confident in tube surgery. So each person's may have a different confidence level, so that can have an impact in the outcome. Now, inclusion criteria already Anisha has explained, and it includes patients who are from 18 to 85 years. So we have already, sir has explained it. The patients, younger patients, will not behave the same to the trabeculectomy and tube surgery like the elder patients. So younger patients can have more of a fibrosis reaction than the elder. And also the elderly patients, suppose they are having anti-glaucoma medications for a long period of time, the conjunctival goblet cells will be affected. And so more chance of a failure rate is more once we are using the anti-glaucoma medications for a longer time. So, but for this particular confounding factor, what these researchers have done is they have stratified the study, and they have divided into 3 stratum. So this age criteria they have given in the stratification, and they have divided it equally so that this confounding factor is taken care of. And then inadequate IOP with maximal tolerated medical therapy, they have not mentioned how many years of anti-glaucoma medications the patients were using. Now, these are the exclusion criteria which has already been discussed. The next in the consort diagram is whether they have showed where exactly the study was conducted. It is also mentioned in this particular study. So this is a consort checklist. Now, next coming into the interventions. So the interventions, whether they have given the sufficient details to allow for the replication, how they have actually done the surgery, whether they have given it or not. So in methodology, the first article they have published, the methodology of the particular study, they have given in detail how the tube surgery and the trabeculectomy is done. So in barrel implantation, it is supratemporal. The surgeon can use a limbus-based or a fornix-based, and they have described the method of the implantation. As well as in the trabeculectomy, also they have given a detailed explanation of how the surgery is being done. So here they have just given little bit of relaxation, like they can do either a limbal based or a fornix based. The sutures which they are using, whether interrupted or a releasable, it is a surgeon's choice. And type of suture material is also surgeon's choice. So there can be a little difference in the outcome based on that. Now coming to the outcomes, they have described the primary and the secondary outcomes. Primary is a cumulative rate of failure, and secondary IOP, glaucoma medical therapy, visual acuity, and surgical complication, as well as definition of the complete and qualified success, which already the Dr. Anisha has mentioned. So here they have mentioned what exactly the failure means. More than 21 millimeters of mercury, or reduced less than 20% from baseline, or less than 5 millimeter, or reoperation or loss of light perception is considered as a failure. Next is the sample size calculation. Sample size calculation is really important in a study because we need to have an adequate sample size so that we can understand whether this particular study can be generalized into a general population. So for sample size calculation, we have to include what is the expected dropout rate. So here, based on the projected differences in the failure rate, 242 patients were included to allow for a dropout of 6% per year. So how they calculated was 88 patients in each treatment group was expected to detect a relative risk of failure of 2 at 5 years, assuming 20% failure rate in the lower risk. So they have calculated the sample size adequately in the particular study. Next is the randomization. So what is a randomization? Randomization is done so that any patient coming in will have an equal chance of receiving any of the 2 treatments. So this is done to generate a comparable intervention group. It is mainly to eliminate the selection bias, and it is a basis of statistical test. So randomization in this particular study was done at the time of enrollment, and as I said earlier, it was stratified. The whole patients were stratified by the clinical center based on either age, whether they are less than 50 or more than 50, ethnicity, African American or the other patients, and previous failed filtering surgery in the non-study eye. These three factors can cause confounding variable, so that they are equally distributed between the two groups. And randomization is done by randomly permuted block scheme. So block size of 2 to 6 is used here, and there was no masking. So next is the statistical analysis. Statistical analysis for the continuous variable was done by two-sided student t-test, and categorical variable was done by Fisher-Exat and chi-square test. And Snellen was converted to logmar for statistical analysis. And for the cumulative probability of failure, stratified Kaplan-Meier survival analysis log-rank test was used. Now coming to the result, the first thing that we have to include in the result is the participant flow diagram. So how many patients were assessed for eligibility? Of them, how many did not meet the inclusion criteria? And finally, how many were randomized and then divided into two? So in this particular study, they have shown that initially 256 patients were divided into 131 and 125 in the trabeculectomy. And unfortunately, 2 in the trabeculectomy group received a tube shunt because of a surgeon error. And in the follow-up, 7% follow-up visits were missed because of death or loss to follow-up. And those who completed 3 years of follow-up visit, we have 103 in the tubes study and 97 in the trabeculectomy study, almost comparable. Now, coming to the protocol violation, in the trabeculectomy group, 1 patient with previous LASIK surgery was included. We do not know why they have included that and not excluded this particular patient. And as I said, 2 underwent the tube surgery. Now, rest of the results, what we have to see is if they have given a baseline data. This is a long baseline data that they have given. Among this, if we compare, you can see that the age group is almost matched, the mean and median, as well as the race. If you see that the blacks and whites are almost equal proportion that we see here. And one thing in the diagnosis that I've seen here is a chronic angle closure glaucoma, but in the exclusion criteria, they have given narrow angles as an exclusion criteria, but still they have included the chronic angle closure glaucomas here. Now these are, they have given a diagram of how they have examined at each follow-up visit, what all examination was conducted. Now coming to the treatment outcome, this is the stratum that they have done. First strata is that no failed glaucoma surgery in fellow eye, but the patient's age is more than 50 years and it's not a black race. Second stratum is failed glaucoma surgery in the fellow eye. And third stratum is no failed glaucoma surgery in the fellow eye and age less than 50 years. So among this, they have compared the failure rate. And overall group, the failure rate is already discussed. You can see that cumulative failure rate is not statistically significant in both the groups. But complete success means there is no failure and the anti-glaucoma medications was not used. That is more in the trabeculectomy group, which is statistically significant. P-value is less than 0.001 by logistic regression analysis adjusted for the stratum. Now, definitions of failure and success was consistent with the recommendations from the World Glaucoma Association for reporting of glaucoma surgical trial. So this is what they have seen. The cumulative probability failure was 33% and 28%, which was not statistically significant. But my question is, can we define a success by an arbitrary IOP level? Because we know that each individual, the susceptibility of the optic nerve head to the damaging effect of IOP varies. It doesn't mean that one patient is not progressing with an IOP of 20, doesn't mean that another patient with the same IOP, they won't progress. So, but for this particular query, they have even done the ancillary analysis for that. So they have redefined the upper limit of the IOP. So when they are keeping the upper limit of IOP as 17% and 14%, when it is 17, it's seen that tube probability of failure in the tube is statistically more significant, and it is the failure is more in the tube group. Whereas when they are keeping at 14 millimeters of mercury as the upper limit, the cumulative probability of failure in both the groups is 49%. Now, this has already been discussed, the reasons for the treatment failure, not going into the detail of that. Now, what they have seen is the trabeculectomy group has decreased IOP statistically significant in all the follow-up months, except for the 18 months and 24 months, even though the IOP is less than the tube group, but it is not statistically significant. Now, the ancillary analysis was also done in patients who underwent reoperations and the loss to follow patients. These patients were actually excluded from the analysis, but they have also performed carrying the last observation forward. They have even compared the last observation before the reoperation and last study visit for loss to follow and found that there are no statistically significant difference between the two groups. Now, this has already been discussed, and the tube group and trabeculectomy group undergoing the reoperations. So these are the reoperations that they were undergoing, but there was no masking. So when there is no masking, there is a doubt whether there is a selection bias. We tend to do more of reoperations when we have complications in a tube group. So, but they have evaluated the selection bias. Evaluation was done in the groups which undergo reoperation and treatment failure, and they have found that no evidence of selection bias for reoperation was seen. But the problem with this is there is a small number in the study, so this can limit the detection of the difference. Now, the post-operative interventions that most commonly used was removal of ripcord, laser suture lysis, and removal of releasable sutures. Now, coming to the early post-operative complications, this particular study has said that the trabeculectomy immediate post-operative complications are more. But if you see, most of the complications are either shallow AC, wound leak, hypotony, maculopathy. All these are because it can be because of a decrease in the surgeon experience in the trabeculectomy, because the tube group is showing less of a complication here and trabeculectomy group is showing more of a complication. But I say that in hands of an experienced surgeon, even these complications can come down to a minimum. Now, prospective studies are expected to report a higher complication rates than retrospective studies. And about cataract progression, it is seen that glaucoma surgery is associated with development and progression of cataract, which is seen in both the groups. Now, coming to the discussion, they have included the limitations, generalizability, and interpretation. Interpretations were similar to whatever results they have already described. And limitations also they have mentioned, as Dr. Anisha has already said that they have mentioned the limitations. Now, few take-home points from the study is that tube shunt surgery and trabeculectomy were both effective in lowering IOP as a glaucoma procedure. And trabeculectomy gives a greater reduction in IOP with fewer medications. And one of the observations what they have seen is if the preoperative IOP is lower, there is a more chance of surgical failure. But the purpose of this study was to help the surgeons choose best procedure for an individual, but the trial hasn't shown any superiority of one procedure over the other. And it cannot be generalized to a different patient population or implant, because ultimately the surgeon's experience and comfort will be different for the different procedures. Thank you.
Thank you, Shweta. That was a very detailed critical analysis and a very welcome critical analysis. Really appreciate it. You can, you stop sharing. Because we are running out of time, I would like to have Dr. George speak a few succinct words about his journey with the RD. Dr. George, please.
Thank you, Dr. Smita. And first of all, excellent presentation, Dr. Shweta. I can understand the difficulty of making this. So I'm also lucky and fortunate to have Dr. Satyan in this panel. And I want to place on record that he was one of the first surgeons. He was probably the first surgeon from Aravind who was involved in the development of this affordable aqueous drainage implant. In fact, I am sure that he went in 2005 to Bascom Palmer and which actually initiated this process. And I was lucky to take it up and follow it up from there. Actually, the whole idea was from probably from Professor Paul Palmer, which Dr. Satyan was mentioning too, who was very passionate of having affordable aqueous drainage implant to resource poor communities of the world who could not have afforded to pay $600 for an drainage implant like the Bowel glaucoma implant. So he got in touch with Professor Alan Robin, who's also one of our mentors and well-wishers of Aravind. And both of them contacted Professor George Bowell, and I was told that Professor Bowell was very happy that this beautiful, wonderful design that he bequeathed to the glaucoma community was now going to be available to benefit a much larger population across the world. So they got in touch with Orolab, and then the basic innovation that Orolab had to do was to cut down on the cost manufacturing. Because the Bowel glaucoma implant would involve liquid silicone rubber molding, which was a huge investment and overhead cost in terms of actual making of this Bowel glaucoma implant. And they innovated by doing a simple compression technology, a simple compression molding of this medical grade silicone, but the actual delay was in identifying the medical grade silicone that could be compression molded, which took a long time. Actually, we were lucky to have Professor Paul Palmberg in Madurai. Even Dr. Satyan was there in the actual launch of this device. And to tell you that this was actually launched in the 4th month of the Tamil calendar, which is the Adi month. And that is how this name came. And Professor Palmberg keeps telling this, even at the World Glaucoma Association meeting, he'll say, so this is the 4th month in the Tamil calendar. This is the Adi month, where excellent things are available at a discounted price across the state. And we present this as the Adi. And then the journey has been to refine this technique. And I think we have gone a long way. And every step in this glaucoma drainage implant surgery has been, we have tried to standardize it. Unlike in trabeculectomy, where I see 9 consultants doing trabeculectomy in different ways, but all those 9 consultants will have the same way in doing the glaucoma drainage implant. Thank you very much for the opportunity.
Yeah, thank you, sir. And Dr. Satyan, would you like to add to what Dr. George said? Anything from your side?
I just want to say thanks to George for pulling me into this development process. Thank you, George. The only thing is, like, I'm not sure whether you people know Dr. Jacob Wilinski. George, you have him?
Yeah.
So he was the first one, before Dr. Paul Palmer came in. But at that time, we were just doing only the Ahmad valve. So it was in 97, I think, 97, 98, that time. Before that, the valve journey was very slow for us. I was in 2003, then slowly it all started, and then George went and he made a huge difference. And then the development process was completely different. That's how the RD came into the picture later. So we are really thankful to Arvind and Orolab for making this device, because it is one of the most cheapest devices in current availabilities, because the bevel is quite expensive. So it has definitely made a huge change, especially for developing countries, whether it is India or any other developing countries. It is really a good one. And just a little bit of 1 or 2 words about the study issues which I was thinking about is on the surgeons, skills, and each center, how the outcomes were, we really don't know, because the paper has not shown us whether one particular center had a higher complications than the other center, which was not been mentioned in that. So that is one thing which I wish to know. If we know that could have really helped us to understand better. It may not have had much, but it could have been better to show up. So, and also looking at the prospective versus retrospective. Prospective can also have a bias in the sense the surgeon can influence the results by doing it the way he wished to. By doing it, showing it that the trap can go for a more failure, he can do more manipulations, or they can do more manipulations in the tube, because it is an open label study. So there's always going to be a positives and negatives in both retrospective as well as in the prospective. So that is one thing which we have to kind of understand. Thank you so much for the opportunity again. Thank you.
Thank you, sir.
Dr. Smita, just one final
Yes.
word.
Yes,
Initially, it was all about affordability, but now I feel it's more about efficacy. We are actually thrilled to see much low-profile, larger surface area bleps in the non-valve device compared to those very localized, high-domed bleps with Ahmed. And that is why, and if you look carefully, all these studies like the TVT, the PTVT, everywhere they have used the bar welt, because I probably think it's more to do with the efficacy compared to the Ahmed glaucoma valve. Thank you very much.
That is a very pertinent point, sir. I really appreciate it. The time is a limiting factor today, but thank you for highlighting the importance of trabeculectomy in the surgically naive eyes, which were medically uncontrolled, as well as in most of the situations where we would prefer a surgery. Thank you very much for participating in this discussion. It was a very lively, very good discussion. Thank you very much.
Thank you. Thank you so much.